And good morning, I'm Dr. Duke Majan. We're broadcasting spine surgery live from Duke Spine Institute here in Melbourne, Florida. Our first surgery of today on October 24th, 2023 is going to be basically 3 herniated discs, but with stenosis on both sides. So we have to go on both sides. He's got leg symptoms on both sides. And the leg symptoms are his biggest problem. He does get back pain as well, but he wants his legs fixed more than anything. Sean? All right, so he's actually got a very posterior spine. And we talk about in prior surgery, anterior versus posterior. And some people's spines are more towards the back, and some people's spines are more towards the front of their body. It's very important. It has a huge impact on the technical complexity of the surgery. We're going to get another x-ray view. We're going to go from front to back, see where the needle is. But we're fixing L3-4, L4-5, and L2-3. L2-3, L3-4, L4-5. Because he's got bilateral leg symptoms and weakness in both legs, he's got pinched nerves on both sides, left and right, at L2-3, L3-4, L4-5. We're going to be fixing both sides. All right. Shot? So there's our first needle. I've already numbed the skin. We're going to place 2 more needles, and the needles are really how we get into the disc through the foramen. Boy. Shot. Shot. The surgery is called transforaminal, meaning we go through the foramen. The foramen is a natural opening already there. Shot. He's reliable. Shot.
Perfect. He's opening his eyes.
Any pain?
Are you having any pain in your legs or your back?
How you doing?
Where's the pain? Leg or back?
All right.
He's got pain in his back.
Good. Yeah, nothing in the leg. That's what we want. Shot. Shot. So I'm directing these needles to enter his spine through holes on the side. And it's hard to appreciate that from the view you guys are getting. Shot. Excuse me. AP. Because we're coming from the side, we're going through a hole that's on the side of the spine. Other surgeons that do back surgery have to take parts of your spine out because they go through the back of your spine. We go through the side. Excellent. All right, let's get a lateral view. All right, so I really ideally want to be bumping up against his facet joint, which is going to be right around here. Shot. And then once I touch the facet joint, I want to slip around it. Just lateral to it. Shot. And that's what I'm doing. I'm actually touching his facet joint there, and then I'm going to slip around it. Shot. And that way you avoid being too lateral. You get right where you need to be. Shot. All right, so you can see from the x-ray view, we are at the L2-3 disc right now. Shot. And we've now accessed, go down just a little south, just about an inch, right there. Shot. Let's count from the sacrum. Show us the sacrum, Jordan. So there's the sacrum, or S1, and then above it is L5, 4, 3, 2. So we are at the 2, 3, 3, 4, 4, 5 disc, and that's exactly where we want to be. We're going to do the same thing on the other side that we did on this side, because he needs both of his leg nerves to his legs treated, decompressed in this case. And it's not just about decompression. I need num. Come on, pay attention. Okay? It's really about irritation of the nerves. And what's irritating the nerves is the herniated disc. He actually has a disc herniation at each level, L2-3, L3-4, L4-5, on each side. Right now I'm giving him some numbing medicine into the muscles to make it feel better. He is awake. We want the patient awake in the beginning. He's awake because I need his help, basically. I have to get around the nerves, and to do that, I actually have to have his participation. He's guiding me. He's helping guide me, okay? And the way he does that is by letting me know, am I too close to the nerve? Shot? So right now I'm touching the facet at L4-5 on the patient's right side. That's perfect. I'm going to go right past it, and I'm going to go into the disc. Now, you can use a lateral view like we're doing right now, but you should always get an AP view to make sure you're in the right spot. You guys see the hole there? We're coming through. It's called the neuroforamen. Perfect. So show us where the neuroforamen is on that lateral view, Jordan. Jordan is going to show you with the mouse right now where the neuroforamen is. It's between one pedicle above, there's that circle, and one pedicle below. So between those two pedicles is the neuroforamen. It's basically a natural opening in the spine that we're going through. And by doing that, we avoid doing any damage to this patient's spine.
Where are you feeling that?
Probably in the back.
What's that? You feel that in your feet? Hold on one second. I'm going to ask you again. Where are you feeling the pain? Where he's working?
Just relax. Everything is okay. You're doing great. All right. We're going to have you asleep in a few minutes. I just need a couple of more minutes and we'll be done. All right. Next, we're going to access through the right foramen, the L3-4. All right, let's get an AP view. This patient's suffering with primarily leg symptoms. Perfect. And when you look at his MRI, you can see on the sagittal views that there's an annular tear and a disc herniation at each of these discs. Shot? And a lot of people think that it's really pressure on the nerves. They call it a pinched nerve that's causing these symptoms. But it actually is more than just pressure on the nerve. It's actually inflammation of the nerve. This is an inflammatory disease. And it's inflammation that causes the problems. I may want to actually make a separate incision for this one, a little bit higher up. Shot? These incisions are very small. These are basically Band-Aid incisions. Shot? They're only 7 millimeters. They heal up within just a couple of days. What takes the most time is the nerves usually take a while to heal because they've been pinched for so long. This is our last level we're going to access, and then we're going to get into the discogram, which would be the next step. Perfect. Yeah. Because of his spine and the anatomy, I had to do 2 incisions on the right side. You doing all right?
How are you doing, my friend? He
So-
said yes.
So let me talk to the audience for a minute while we get ready here. But basically, this patient has 3 discs that are damaged, actually 4 discs that are damaged in his spine. And 3 of them are causing his current symptoms. The 4th one is not, and that is the L5-S1 disc. If you look at the x-ray, it's extremely degenerated and collapsed. And I debated treating it, but I felt based on the MRI, based on the patient's symptoms, and the way he had leg symptoms, you know, when he was up walking and doing stuff, that it was not a cause of his symptoms. Because there's a dynamic component to his leg symptoms. He doesn't have them all the time. He has to be up moving around to get the symptoms. When you look at L5-S1, it is not moving, it is not bulging out at all. There's no disc left. And it doesn't look like there's any issue or inflammation going on at that disc. So basically it's not moving, but his symptoms get worse when he's moving. So that means it cannot be causing his symptoms. It's just a deductive process, and it's borne out over time that it's true, okay? So I'm leaving L5-S1 alone. I'm just treating L2-3, L3-4, sorry, L4-5. I'm leaving L5-S1 alone. So L5-S1 will not be treated because it's not causing symptoms, in my opinion. All right, now he does have back pain, and the main reason he's having surgery is not his back pain, it's his leg symptoms going down his legs. But he does have back pain as well. So we're going to figure out where it's coming from. Are you comfortable? Any pain?
Are you having any pain right now?
Are you having any pain?
He's having discomfort on the right side.
All right. Is it better now? That's the side we just went in. All right. How bad is that on a scale of 1 to 10?
Give us a number. This is the number.
What's the highest it goes?
You said an 8? 8.
I heard 9. All right. Is that where you get pain? Is that where you get your pain when you get it? How come these? Yeah. All right, 9 over 10, concordant L2-3. How come this looks so much more dilute?
It's the same water. This one was the first one that I ate.
Fine. All right, you better now? Better? How bad is that on a scale of 1 to 10?
Give us a number.
How high does it go? What's the highest it went?
6.
6. Is that where you get pain? All right. So when I injected him, his whole body jumped up and he went, "Oh." And he calls it a 6, which is fine, but it looks far more than a 6. All right. 6 over 10 at L3-4. Is it better? You guys see the dye on the other side? That's because these 2 needles are in the same disc. How bad is that on a scale of 1 to 10? 10 being the worst pain.
9.
9 over 10. All right. Is that where you get your pain? All right. 9 over 10 at 4-5. You could see at each level. Jordan, show us at each of these levels. There's an annular tear. Okay. There's a herniation. And you could see the dye leaking out around the nerve. So just like the dye leaks out around the nerves, inflammatory materials that are very irritating to the covering of the nerves leaks out as well. And that's what causes the leg symptoms. And you count from 1 to 100. When you wake up, we'll be done. So he's got back pain, and that's been bothering him. But what bothers him the most is when he's up walking around, he starts getting numbness and tingling and weakness in his legs. We call that neurogenic claudication. Very common problem with people with herniated disc and spinal stenosis. All right. Now this patient actually travels to us from Chicago, Illinois. Shot? Shot? We're doing the bottom, right?
Yes,
At this point, I'm removing the needle, leaving a guide wire, which we pass through the needle. And I'm going to now use the dilator to go down and spread the tissues. If you ever look at your MRI, you can see the muscles in the back have fibers. They're called fibers. They're literally just like the fibers of clothing, like cotton fibers on your jacket or your pants or your shirt. And like any fiber, they can be spread apart. That's what this dilator does. It's designed to spread the fibers of your muscles without damaging them, or minimizing the trauma, basically. That's why this is called minimally invasive surgery, because we're doing it through a very small incision with minimal to no damage to the patient's body. So that went in really easy. That means there's a giant tear on that left side at L4-5, which I could see on the discogram. He has a giant tear. So that tear is in the annulus, and there's a herniation in the tear. It's keeping the tear open, and it's preventing the tear from healing. How is he? Good? Shot? All right. Next, we're going to bring our tube down. It's going to go over the dilator, and then we're going to take the dilator out. Shot. And you can see what's left is the tube. Now, people ask me all the time, Dr. Dukmajian, but if you go in that disc like that, aren't you damaging the disc? The answer is no. The disc is damaged. We're going through the damaged part of the disc. We're passing through the herniation. We enter the disc where the herniation is. We push the herniation back into the disc. And then we go take the pieces of herniation out from inside the disc. So we're not actually damaging the disc. We're not removing the disc. We're not doing a discectomy. We're doing an annular debridement and what we call a herniectomy. A herniectomy means to remove the hernia. If you say a herniectomy, ectomy in medicine means to remove. A herniectomy means to remove a hernia, right? A discectomy is to remove the disc. All right. There's the laser. Which machine? 60 or 100? 100. All right. We're putting our new laser to work. Folks, if you're watching this surgery, you're welcome to ask questions. I'll answer them for you while I'm operating.
As of now, we have 2 questions.
All right, but before we answer any questions, I'd like to explain to the audience why do disc injuries, and I'm going to call it a disc injury because you're all used to hearing words like herniated disc, bulging disc, protruded disc, extruded disc, ruptured disc, slipped disc, extruded disc, and they're all the same thing. People ask me, you know, what's the difference? There's no difference, folks. There's no difference. I promise you, there's no difference. They're all basically the same problem. And the problem is the world is focused on terminology. And the terminology, though, is based on structural abnormalities that are subtle differences of the same problem. Disc pain is not a structural abnormality, it's a physiological abnormality. And physiological things are processes that are not visible to the naked eye. They're not visible to the MRI typically. There are certain types of MRIs that can be done that look at physiological processes, like functional MRI. Okay? Functional MRI is a really interesting type of MRI that gets a structural view but also lays over on top of it a physiological view of what's happening. Okay? So basically The type of MRIs done for back pain are just structural MRIs, and the terminology used, even though it's different with respect to disc injuries, is all the same. It all results in the same symptoms, the same process, the same problem. It's about inflammation. So let's show the audience why does a herniated disc cause so much inflammation. I want to see it too. All right, welcome back. You can see what I was talking about, that herniated disc, bulging disc, ruptured disc, they all cause symptoms by inflammation. And what causes the inflammation is the herniated disc, the herniated nucleus within the annular tear. That inflammation then spreads to the rest of the disc, and it can get on the nerves, which are just behind the disc, because the nerves run behind the disc. Let's take our first question. There's a piece of herniation right there. You guys have seen these herniations coming up, little bits at a time. But go ahead.
This first question comes from Fiona on YouTube.
And good morning, Fiona. Welcome to our live stream.
They asked, "Hi Doc, do you know of any specialists who perform this surgery in Australia?"
Hi, Fiona. Unfortunately, the answer is no. We developed this technique here at Duke Spine. We started by performing all the other spine surgeries available in the world and found that they were essentially ineffective. They didn't work for this. There's only one surgery besides this that works for disc pain, and that's fusion. But it has to be done at the right levels. It has to be performed the right way. And even if it is, it's very destructive to your body. So for 26 years, I've been doing fusions, and I learned that this procedure is better than the fusion. But the fusion is the only other procedure that works, in my opinion, at this time in 2023. And there are fusions being done in Australia. So the problem is finding a surgeon who can diagnose your pain properly and then treat it properly with the right fusion. I have found that the majority of patients with back pain from a disc problem, they have 2 discs that are causing the pain, 2.5 to be exact, and on average. So you're going to have to find a doctor that, number one, can make the right diagnosis, which is very hard to find, about 1 in 1,000. And then number 2, they're able to do more than 1 disc at a time with their fusion surgery, because most of them will only do one disc, which means you're still going to have pain after your surgery if you have more than 1 disc causing your pain. So that's the dilemma for people, is they're being misdiagnosed and undertreated. And the surgery is important. You got to do the right surgery, but you also have to have the right diagnosis, because if you treat the wrong area, the wrong level, then the patient's not going to get better. So for example, this patient has 3 discs that are causing symptoms. Most spine surgeons would look at the L5-S1 disc and say, that's the problem, let's go fix it. They would do a fusion at L5-S1, and guess what? The patient would have worse pain because the 5-1 is not the cause of his symptoms. It's actually the discs above. So then he would end up with more pain in his back and legs. The surgeon would say, well, your surgery went perfect at L5-S1, there was nothing wrong, and the patient would be suffering. The surgeon would throw their hands up and say, I don't know what to do, go to pain management. And then they would start looking at you funny like, you must be faking your symptoms because I fixed the bad disc on the L5-S1. Maybe you're just faking it because you don't want to go back to work. And they start to blame the patient for their own failure to accurately diagnose or treat the problem. And this, we see this all the time. Not here at Duke Spine. We don't do that to our patients. We know how to make the right diagnosis. The problem is other doctors don't. And it's complicated. That's why you have to go somewhere like Duke Spine Institute to get the best care. I'm not just trying to get you to come here. I really am not. But if you want to be fixed, you got to come here to get fixed. You're going to have a hard time getting fixed anywhere else. You know, spine surgery on the back to treat back and neck pain, it's not like going shopping for clothing. You know, you can go with one brand or another brand. It's all clothing. It's all about the same. Or even a car. Cars aren't that different. But when it comes to spine surgery, there's a huge difference in the outcomes. And unfortunately, most of them are bad. So you really got to be very selective where you go for your care. But I'm telling you why. We're not doing magic here. We're just treating the right thing. And we're treating we're not under-treating patients. We do it all in one shot, okay? So come to Florida. It's worth it. You won't be disappointed. Yeah. Next question.
Next question comes from Bali on Facebook. And they ask, how to diagnose if pain is coming from the SI joint or the L5 to S1? Would the SI joint issues show up on the lumbar MRI?
Great question. The answer is the only way to know if pain is coming from an SI joint is to do what's called an SI joint block. That's where the doctor puts a needle inside the SI joint. They have to use the X-ray machine. They have to inject dye into the joint at the same time they treat it so that you can see the joint was accessed properly and that the medicine went into the right place. If you do not put the medicine in the SI joint, then you will never know if the SI joint is the cause of the pain. So it's called an SI joint block. And there are doctors that can do it. We do that here at Duke Spine Institute. And that's how you do it. Once you know the SI joint is the cause, then you have to treat the SI joint. And typically we start with a steroid injection to reduce the inflammation in the joint. But if the pain comes back again, then we tell our patients there's a permanent fix, and that's called Duke plasma rhizotomy. Duke plasma rhizotomy. And that's where we go and we deaden the pain nerves, kill the pain nerves to the joint. It takes about 15 minutes to do. It's outpatient. It's very safe, and it works very, very well. We've not had a single failure. We've been doing it now for 1.5 years, over 100 patients. Very safe, very minimally invasive procedure. All right, very good question so far. So the answer is you must do an SI joint injection, a block. That's the only way to know for sure it's the SI joint. Now, if the SI joint, if you do an SI injection and it doesn't get better, that means it may be the L5-S1 facet joint, in which case you should do an L5-S1 facet block. But the physical exam should guide the doctor to pick the right one first to test. And the facet joint is located higher up than the SI joint. It's located further up the back. Just about done with this disc. You guys see the end of the disc right there? You can see the fat. in the epidural space.
Yes, we do.
All of this right here is scar tissue from chronic inflammation. I'm going to show you guys the nerve root so you see exactly where the nerve root is. It's literally up against this annular tear, this herniated disc. Just give me a second and I'll show it to you, okay? Any other questions?
Yes, we have another question from the Rose Stella on YouTube.
Oh, yes, the rose is back.
And they asked,
Welcome back.
the laser, which is using a photon energy or electric energy?
Great question. So the laser uses laser energy. I think the wavelength is around 2100 nanometers. So it's electromagnetic radiation. It's not, I believe it is, I guess, photon I'm thinking as a quantum of energy of electromagnetic radiation. So it uses electromagnetic radiation, just like microwaves, but if you look at 2100 on the spectrum of electromagnetic radiation, it's a high energy type of electromagnetic radiation. Microwaves, radio waves, those are all, even visible light, those are all forms of what's called electromagnetic radiation. And electromagnetic radiation is electrical, but it's also magnetic, because anytime there's an electrical current, it generates a magnetic field. So it's complex physics, but electromagnetic radiation is what it's called. So laser energy is within that spectrum. All right, that should be it. Let's take a look. The nerve is right there in that fat. You guys see that? The little white streak? That's the nerve right there. I went the laser back. There's a little bit more I want to get right there. You guys see the blue right there?
Yes, we do.
Yeah, so I just want to zap that as well. But that's how close the herniation is to the nerve. That's why disc problems cause leg symptoms, because the nerve down the leg is right there, that white thing. It's just got a little bit of fat around it because it uses the fat for energy. But the disc herniation's gone. You can see it. It's gone. All right, and that tear right there will actually seal itself off. It takes about 9 months to a year to completely close. So there's no way to close it humanly possible except for the patient closing it. Scientists have tried developing things to put there and they don't work. They don't work. Okay? There's lots of things that you can put, but they don't work. And I don't believe in doing treatments that don't work. Okay? Period. Now there's a lot of money being exchanged hands on things that try to close the tears, but they don't work, so I don't get involved. Duke Spine Institute, we do treatments that work. We don't do treatments that don't work. So if we're not doing the treatment here, that means it doesn't work well, or there's a better treatment, safer treatment, more effective treatment available. Okay? Unfortunately, other doctors don't know how to do our treatments. So they're doing the things that don't work. Yeah. Yeah, Dr. Berndes, our head of anesthesia here, has brought up a great point. You know, we don't talk too much about this during the surgeries, but we had 2 patients just this week alone that are having surgery today that had PRP and stem cells put in their spines to cure their back pain. And of course it didn't work. They're here to get the surgery done here. My point is there are plenty of doctors out there willing to do treatments that don't work. And the reason is they don't know how to do a treatment that does work. So they're trying everything that's out there that doesn't work because the treatments that work are only done here at Duke Spine. And they don't know how to do our treatments. That is the Duke laser disc repair, the Duke plasma rhizotomy, and shot. And I'm not trying to brag, I'm just trying to tell you guys the truth. I found this out over the years of doing spine surgery for 26 years. I've seen so many treatments done on patients, millions, that just don't work. Num num. All right, next question.
Next question comes from the Rose Stella once more on YouTube.
Yep.
They asked, in the future, can we expect the disc regeneration?
In the future, can we expect the disc regeneration? I don't know how to answer the question. I don't know if the Rose Stella is asking, after the Duke laser disc repair is done, can we expect the disc to regenerate? The answer is yes, absolutely. The disc will seal and heal, unless you re-herniate. If you re-herniate, then the disc will not heal, and you'll have to come back and get surgery done again. The re-herniation rate for this surgery is 1%. 1 out of 100 patients re-herniate. Now, if you're asking, will the disc regenerate on its own? The answer is no, it will not. It will not. The disc will never regenerate on its own. This problem with discs has been around for as long as human beings have been up walking around injuring their discs. And so it's never evolutionarily fixed itself. And unfortunately, people with disc pain, they have it for 20, 30, 40, 50 years until they die. And it just cripples them. Huh? Yeah, it cripples them. And basically, they don't have a quality of life. Shot? That's good. Yeah. And basically, they die with the pain. So it doesn't go away. It doesn't, the disc does not regenerate itself. And I don't foresee any technology in the near future that you can just magically zap the disc with something and it's going to regenerate. This right now, what you're watching, is the least invasive, most effective technology available to humankind to fix back pain from a disc. It is the Duke laser disc repair, okay? And it's not that I want it to be, it's that it is. And the reason it is simply because I discovered where the pain is coming from, and I target the treatment to that exact location, which is a tiny little spot in the disc. And by the way, people that get MRIs done before and after surgery, those MRIs that do not look any different. That's how minimally invasive the surgery is. We're not trying to make your MRI look different. We're trying to make you feel different. And the pain you're experiencing is not something you can see on an MRI. It's something you feel, and it's coming from the inflammation within the tear. Why don't we show the audience our video on how the Duke laser disc repair actually gets rid of that back pain from the tear. It's very, very minimally invasive. What you're seeing right here, folks, is 5 millimeters. This is a 5 millimeter left to right, side to side, up and down. This tube is about 5 millimeters on the inside. So that's a very small little space. And you don't see changes on the MRI, okay? And I get people all the time saying, well, you see a big difference on the MRI. You don't see anything on the MRI. There's no difference. You can't see pain on an MRI. You can see structural abnormalities. You could see damaged discs. You could see stenosis. You could see facet arthropathy. You could see lots of things. But you can't see pain. All right, Henry, let's show that video. Grab her. All right, so welcome back. We're actually lasering here on the left side. What are we at, 3-4?
Yes.
And you guys see that down there? Look at that, isn't that cool? That is the needle from the opposite side. There's a piece of herniation. Okay, you guys see the needle from the opposite side? And look at my laser hit it. And look at it, welded it right there. Okay, I couldn't see it, it was buried in the herniation, and I literally hit it and welded it. So that's why we go from both sides, because the patient has symptoms on both sides. But anyway, hopefully we can separate it and get the stylet out. But that's the needle from the opposite side. All right, we're just about done with this one. But go ahead, I heard we had a question.
The next question comes from Becky on Facebook.
All right, Becky, welcome to our live stream. Thanks for joining us.
They asked, when you look at a person's MRI, what do you look for to make a decision if they are a candidate for you to do surgery?
Becky, that's a great question. So the most important thing I look at, Becky, is not the MRI. I look at you, the patient. I look at the MRI, but I also look at where is the pain on your back. Because there are 30 causes of back pain. 30. And by the way, the new Duke Spine Institute website being launched in January of 2024 is going to have those 30 causes of back pain. And you can actually play with our animation. And you could see all, 30 causes. And you'll understand that each cause is located slightly different place than the other ones. There's a little bit of overlap, but it's very minimal. But basically, I use the physical exam to get an idea of where the pain's coming from. Now, I have to tell you, there's other things that factor into it besides the physical exam. For example, I have this deep knowledge of back pain that very few people have. And we're actually going to be building an AI algorithm and platform to help take my knowledge and make it available to the entire world, as though I'm actually there for each patient, each person, interacting with Duke Spine Institute's future AI algorithm. I have Sanjay in the room here watching, I believe, and he's going to help me build that. But if you look at the map of pain, you can see that there's different things in different locations. So because pain is highly localized in the back, I can actually diagnose the source almost with complete accuracy just by looking at your back and touching your back. So that's the most important tool to me, is the exam and my knowledge. And why is the knowledge important? 2 reasons. Number 1, it creates a map. And number 2, I have an understanding of what's called the relative frequency of each of those problems, okay? I'll give you an example. Let's say you surf, all right? Let's say you're a surfer and you like to surf in Florida on the beach. And you're out there in the water and suddenly you see a fin pop up, okay? Well, that fin can be several different animals. And depending on what animal it is going to make a big difference in how you respond, okay? Now, it could be a dolphin, it could be a shark, and, it could be something else like a turtle putting its flipper up. The point is, you got to make a diagnosis really quick, because if you don't, you make the wrong diagnosis, you could be screwed. You could be somebody's lunch, okay? So you got to ask yourself, what is that fin? And you want to be right, but it could also be a tiger shark, a bull shark, or a great white shark, okay? Or it could be a sand shark, it could be a gray reef shark, but it's unlikely. So you got to know, it could be a hammerhead, you got to know what it is. And so that's where my experience comes in. I could tell you what kind of fin it is. I know enough about sharks, I could tell you. I could tell you what a tiger shark fin looks like. I could tell you what a hammerhead fin looks like. I can tell you what a great white fin looks like. I can tell you what a bull shark fin looks like. I can tell you what a dolphin looks like. Okay? So you got to know what you're dealing with. And that's where my experience comes in, that nobody else has, by the way. They just don't. Doctors don't have it because they don't treat pain effectively. They don't know where it comes from. They just do shotgun approach. So that's what you're getting when you have somebody like me help you figure out where your symptoms are coming from. That's why people travel around the world. It's not just because we do these amazing surgeries nobody else does. It's because we do these amazing diagnoses nobody else does. Okay? Now I'm going to tell you about the sharks, okay? There's an incidence of those sharks, a relative incidence. For example, tiger sharks are not that common in Florida. Okay? Great white sharks are not that common, but they still occur. The most common is a bull shark. And so when you're looking at that fin, you got to combine not just the anatomy of the fin, what it looks like structurally, that's the MRI, by the way, but you got to combine it with your knowledge and experience for that area. Okay? So it's not just the fin, the anatomy, but it's also the relative likelihood that that's you know, that kind of shark is in that area, or that kind of animal is in the area you're in. That's where my experience comes in. That's why it's worth using Duke Spine Institute's free MRI review to make a diagnosis as to what's causing your pain, because other people are not able to do that. All right, next question. I figured Carrie would appreciate that analogy. Next question.
No current questions.
All right, very good. We're almost done with the laser. You guys see the laser there? By the way, just so you understand, that glass fiber right there, that glass fiber is 1 millimeter wide. This is what's been pushing out every time he stands up. This is right here, all this scarred up herniation has been pushing out, pinching his nerves. And that's what I'm here to remove, as much of this as I can. Now, I've said this before, and I'll say it again. It's worth hearing that when we remove a herniated disc or herniation, we're not taking 100% out. The best we ever do is around 80%. 80%. No surgeon alive can get 100%. Okay? It's not possible. So the best we could ever do is 80. If we get 50%, the patient's symptoms will go away. So I just need 50%. Why is that important? Because you can't reach 100%. It's not possible anatomically. These herniations are not accessible through our small little corridors, no matter what surgery you do. Even if I were to open you up completely and do a fusion, I still can't get 100%. I could probably get 60, 70%, even with an open back surgery, okay? So it's important for patients to understand you're never going to have 100% of your herniation removed. You might get 50%, and that's great. If we can get 50%, you're not going to have any more symptoms. Hey, will you write that down and remind me to add that, Sanjay, to the to our fact sheet? Send me an email. Say add it to the fact sheet. Oh, I'm grabbing the needle. I could feel it. Huh? You can see it? Yeah. I'm trying to remove some of this stuff, and I'm grabbing that needle down there. I could actually hear it and feel it. All right, we're just about done here. I can't really get any more, and I've gotten enough. The nerve is going to be right up there. I may get a little more. Let's see. No, there's really nothing left to get. But you see, well, let's see, maybe right there. Let me have the laser. If you're a spine surgeon doing this stuff, make sure you look laterally. Laterally means the opposite direction of where we mostly work. We mostly work medial to the 12 o'clock. But you got to check your 6. You like that? Got to check your 6. Because the 6s also could be pressing on the nerve. That's just fat right there. We're done. Okay, done. So that's 2 down, 4 more to go. What time do we cut skin? That's when I placed the first needle? An hour? No way. Took me an hour to get here? Geez, you guys are slow. You like that? You never blame the surgeon. That's why the surgeon has so much help in the room. That way we can blame other people. I know. I'm not rushing or anything, but I sure would like to believe we're a little more efficient than that. All right, 2 down. Let's go. Bring in the fluoro. So I'm going to finish the left side, then I'm going to go to the right side. All of this surgery is done through 7mm little cuts on the back. Almost bloodless surgery. Okay? We lose about 1 or 2 cc's, milliliters of blood, which is as much as you probably lose 10 or 20 when you have a nosebleed. So we're losing 2. And if you have a nosebleed, you're losing 10 or 20 cc's, maybe more than 20, right? 30? I don't know what the average nosebleed. Yeah. So this surgery loses like far less blood than a nosebleed. It's pretty much bloodless surgery. There's no hospitalization. This patient will go home. In his case, since he's from Chicago, Illinois, he's here with his lovely wife. They're going to go back to their hotel as soon as he's done with surgery. Shot? All right. Pretty cool, huh? Any more questions?
Yes, we have a question another question from Bali once more on Facebook.
All right.
They ask, what causes severe stiffness in the lower back? Is it the actual disc, the tear, or the inflammation?
Yeah, the stiffness in the back is usually caused by the facet joints. Inflammation and arthritis in the facet joints. Facet joints. We can fix that. We can't get rid of the arthritis, but we can get rid of the pain. And the stiffness usually goes away after a few months after treatment. The treatment for that is the Duke plasma rhizotomy, the DPR, Duke plasma rhizotomy. We go in and we deaden the pain nerve. We cut the pain nerves to each of those joints. So it takes the pain away. Then you can actually move and twist and get back to feeling normal without that pain. Now, to make a true diagnosis, I would need to see your MRI and I need to do a physical exam. So I'm just telling you what I'm thinking based on what you're saying. But obviously, for me to know for sure what's causing your pain or your stiffness, I need to examine you. I'm just telling you the most likely cause is the facet joints. Could also be the SI joints, which are like a giant facet joint for the sacrum. All right, look at that. Pretty cool. You see all that red stuff? That is inflammation, inflammatory tissue. That's what we're here to fix. That's where all the pain and the leg symptoms are coming from, inflammation. This is L2-3, by the way. L2-3. Ready? People ask me about the accuracy of the laser. It's in the right hands with the right equipment like ours, it's 0.1 millimeter. 0.1 millimeter, a tenth of a millimeter. In other words, I can peel herniations off at a tenth of a millimeter. That's how accurate it is. And there is no other surgery in the world that comes even close. It's probably around at least 20 times more accurate than open surgery. Because open surgery, you can get about 2 millimeters of accuracy. Any other type of surgery. So it's the most accurate surgery in the world. But you have to have endoscopic with it. It's not just the laser. The laser can be precise, but you have to have the optics and illumination, magnification to go with it. Okay? So by itself, the laser would not, it is precise, but its operator is not precise. That's the surgeon. So to have precision, you have to have visibility of your target. You got to be able to see the target. And that's where the endoscope comes in. And the minimally invasive part is, of course, the approach, transforaminal. Good job there, Destiny. Way to stay on top of it. You like the laser? It's pretty cool, huh? Pretty cool machine. So you all want to know why healthcare is so expensive. It's the big companies that sell products in the healthcare sector that make it expensive. It's the insurance companies not paying and making you pay for your medical care that makes it expensive. As an example, since we don't have any questions, right? Henry?
Repeat that one more time. I'm so sorry.
Do we have any questions?
No current questions.
Yeah. So one of the challenges Duke Spine is facing is the laser we use, which is the most amazing laser in the world, made in Israel. That laser company was bought by a giant, very powerful, very rich company called Boston Scientific. And they paid $1 billion for the company, Luminous. And now they're phasing out these lasers we're using and replacing them with a laser twice as expensive to buy. Now these are already $130,000 each. So the new one is going to be over $200,000. And worse, they're making it so that all the parts and supplies are far more expensive. They're jacking the prices up. So who do you think is going to pay for that?
This is the only laser company in the world that produces these products?
Yeah. So the question was, is this the only laser company in the world that produces these lasers? The answer is yes. And that's why the American company, Boston Scientific, paid $1 billion for it, because they have patents, right? So nobody else can compete with them. It's basically extremely anti-competitive, and I hope the government comes in and regulates it, but that's not going to happen. The government's supposed to prevent anti-competitive behavior. This company has 90% of the market. 90%. So, I mean, where do you draw the line that that's a monopoly? To me, that's a monopoly, okay? And they won't allow their technology to be shared with other companies that can compete. So long story short, you're forced to pay outrageous amounts of money. Now, we've been inside this laser machine. We know what it looks like. We know what all the parts are. And the cost of manufacturing the parts is somewhere around $10,000, parts and assembly, in my estimation. So the profit margin is for the new one, $190,000 profit on a $10,000 machine. It's obscene. It's just greed at its finest, okay? But I can't control it. The only thing I can do is respond, because I don't make the laser, I don't sell it. But this is typical for companies in the spine and orthopedic and medical world. Yeah, it's a free market, I get it, and we all like free markets, but at the same time, when it comes to healthcare, there should be some type of, I don't know, ethical, moral regulation on, gouging people and hospitals. And the worst thing is the insurance companies are not wanting to pay for newer technology like lasers. So who's going to foot the bill? In the end, it comes down to the patient has to foot the bill. So they're really basically overcharging the patient. That's really what it comes down to. And that's why I get upset about it, because patients are struggling to make ends meet. Look at that herniation. That's a biggie. Okay, and I had to use the laser to free it up, right? To get it off the annulus where it was stuck down. By the way, we're not doing a discectomy, we're doing an annular debridement, which is the Duke laser disc repair procedure. It's the only procedure in the world that does this annular debridement. Now, other people can copy. I can't stop them, but what they're copying is us. And we're the first to do it. We've been doing it now for 17 years, since 2006. And we're the best in the world at doing this surgery. And there will be copiers, there will be copycats, there's no doubt. There already are. I'm aware of them in India, China. And they don't do exactly what we do, of course, because they can't afford to do what we do. They don't have the same equipment. But they're trying to do it, and they're doing it little pieces. Well, you can't do that. You have to have it down to where you're not doing that. Okay? That torque will force it really out of your hand and my hand, and then you have that fiber flapping around. All right, any questions, Henry?
Yes, we have a question.
You see the needle from the other side? Right?
Yes, we do.
Yeah, because we're doing bilateral. Go ahead.
This next question comes from Fiona, once more on YouTube.
Okay.
They ask, is the rhizotomy of the facet joint treatment permanent, or does the nerve grow back?
Fiona, great question. So the rhizotomy done everywhere else in the world is temporary. It's called a RFA, radiofrequency ablation, RFA. But at Duke Spine Institute, we have a permanent rhizotomy. We're the only ones in the world with the permanent rhizotomy. And it is patented, meaning we're the only ones who are allowed to market it and do it. It's patent pending, I should say. It's not patented, it's patent pending. Patent pending means we've submitted it for patent, and the government is going to review it and hopefully award us the patents. But it's too early to say. But that said, we expect to get a patent because nobody else has ever done it. And we're the first to do it and the first to apply for a patent for it. So we expect to have a patent. But the point is that Duke Spine offers a permanent rhizotomy. It's called the Duke Plasma Rhizotomy. We use a very high energy called plasma to destroy the pain nerves, to cut through them and destroy them, so that it gives a permanent effect. We've only had 2 patients out of hundreds that we were not able to completely burn the nerve. We had to bring them back and burn it in certain areas again. But that's in, say, 1,000 nerves we burned. There were about 3 nerves that didn't get burned properly, and we had to repeat it. And those nerves were not burned properly because the patients had very complex spine history where they had all this arthritis in their spine, and the arthritis was blocking the wand from working. So we had to bring them back and redo it. But that's not bad, you know, to have 2 patients or 3 nerves out of thousands that we were not able to completely burn. And we brought the patients back and redid it at no cost, no charge to the patient. So it's a great technology. There's nothing else in the world like it. The other thing you can do for facet pain, besides the rhizotomy, is fusion. Fusion will take pain from the facet joints away. However, it will also cause a lot more problems, and you don't want to do fusion. So you can get adjacent segment disease and have more pain later on, and then you have to do another fusion. The best treatment in the world is the Duke plasma rhizotomy right here at Duke Spine Institute. We do them every week. As a matter of fact, the next surgery will be doing a Duke plasma rhizotomy, right? Yeah. We're going to be doing the Duke laser disc repair for the disc problem. We're going to do the Duke plasma rhizotomy for the facet problem.
Yeah, we have that one later. Next one, just DPR.
Now, Sanjay, when Henry was gone, we had a couple of DPRs we did that you were supposed to get uploaded to the playlist on YouTube. Whatever happened with those? You're supposed to meet with Henry and get them put on. Can you make sure that happens today in between these cases? Did Sanjay hear me?
I believe so, yes.
Yeah.
So we'll get that going, not a problem.
Yeah, thank you. They just need to be added to the playlist, that's all. They're already, you don't need to edit them or anything. All right, we're almost done with this side. I'm going to move over to the right side in a moment. We've got about 30 seconds left. How's our patient doing, doctor? All right. Wonderful. So far, we found the herniations. These are older herniations, not younger, newer. They're older, lots of scar tissue. That's what all this white stuff is. And I have to release the scar tissue as well as the herniation. This is what's been bulging out, pushing on his nerves. So he had not just a inflammatory component, but also a structural component. And that's most herniations are a combination of inflammatory and structural. They have both, and his is both. He has both inflammation, that we talked about earlier, that's causing the back pain, but also some leg symptoms, and he's having a pressure from the bulging out of the herniation, all this scar tissue. It's very hard. It's kind of calcified here. So I'm zapping it all away. Remember, we're not going to get 100% of the herniation. We're only going to get 50, okay? But that's plenty enough to last his lifetime. I think we're done here. Yep. Great. If you have questions, feel free to type them up and ask me. I'll answer them for you. We're irrigating. Just thinking. Yeah, I think the move to the dilute iodine was betadine was the right move.
Yeah.
Don't put your hand there. All right, done with the left side. Hold pressure. I'm coming to that side. You cannot hold pressure. I have to come to your side. You got to move out. All right, any other questions for me?
No current questions.
Great. We're halfway done with the discs. Come on in, Jordan. So we're using the X-ray machine to navigate and localize. Those are the two words to remember. Localize, navigate. Localization means we're identifying the target, localizing it in space. Navigation means we're getting to the target. Is that it? Yeah? All right. Shot. Where is the guide wire? There it is. So we're starting with the 4-5. Now we're going to bring the dilator. Take a look at the dilator. You guys see this here?
Yes, we do.
See how the tip is tapered? So it doesn't cut muscles that it goes through or fascia. It spreads the fibers. Everything okay? And that's important. It's an important distinction because cutting is never good. Spreading is always good. In surgery, you want to spread when you can. Shot? Shot? Other surgeries like laminectomy cut. And Henry actually has some really nice footage of what it looks like to do a laminectomy. Sorry, I do that to my kids too, believe it or not. When I need their attention. My girlfriend taught me that. Did I ever tell you that? She was from Nicaragua. She was from Nicaragua back in college. She taught me how to get attention if you need something in a polite way. All right, very good. So big tear, the dilator went through the herniation and tear easily. We're going to go in there and clean it out. Does Carrie have any questions?
Hold on one moment.
That's good. Well, just that's good.
Carrie asks, with each disc that you address, how many nerves do you work with?
How many nerves
On
do
each
I
side.
let?
How many nerves do you work with on each side of the disc?
Yeah. So
On each side.
the Duke laser disc repair, we don't count nerves. We count discs, and we count sides. But the nerves you're talking about maybe are the burning of the nerves to the facet joint. You're going to see that in the next procedure. So here we're just treating a disc. Now the nerves that we are near on these procedures are called the nerve roots. And the nerve roots are big. They're big white things. You never want to hurt a nerve root. Nerve roots carry motor and sensory nerves. And basically, they're the ones that are responsible for movement and sensation in your leg. So what we're doing is we're working between them. And we're working between two nerves. Everything okay?
Yeah, that's already. Remember?
Yeah. So we got the foot pedals with these, right?
Yes.
And this is the new foot pedal?
No, this is the old one.
Why?
Because the new foot pedal that come with the machine is enclosed. I don't know if you like that one or not. You know, it's a single pedal, but it's like in a box. I know you like a swing around with your leg. I can ask you if you have a different one from the, you know what I'm saying?
You
Like
need
it's
to.
not open on the side.
I didn't buy these to settle. Okay? I bought them because they're supposed to be the same of what we use, Luis.
Yes, sir. No problem.
I wasn't aware there was a different foot pedal. Yeah, we need to have this foot pedal.
No problem. I'm going to ask it to switch it.
Well, you can ask them, but that's supposed to be done before we pay. Once we pay, you can't get the money back.
No. We're going to have the foot pedal.
Especially these machines we paid a premium for.
No, it's fine. Thank you.
And when you talk to the Israelis about that unit over there, I want you to look at the foot pedal. Make sure that it's, because it's a 2023 machine, right?
It's, yes. Well, the email that I read about you.
It was a 2023.
Yeah.
Well, you need to make sure that it's the foot pedal I like
No problem.
for that kind of money. I'm sure shipping is going to be very expensive. Any questions, Henry? Henry, what's the best way to ship something from Israel
Best way to ship something?
to the United States?
I mean,
Yeah.
in my opinion, it would be by plane. That's just the fastest. But
Yeah, but FedEx.
FedEx is probably the way to go.
I thought you were going to strap it on your back and swim it across. DHS.
I could try.
We're looking at buying a laser from Israel. China. Don't even talk to me about All right. You can. Go. You know, put the plane on autopilot. You like that? Put the anesthesia plane on autopilot. You like that?
We got a good plane on him, so
I know. That's what I'm saying. If you got a good plane, put it on autopilot. Yeah. Huh? Is there any equipment you need? Luis, you got to fix the pedal issue.
yeah. It's not an issue.
I don't like surprises like that.
No, it's fine.
It is a surprise. I mean, I thought we had the same pedal. Why don't you you need to get the pedal so I can try it.
I have a question.
Next case. I'll tell you if I hate it. Yes.
The next patient is having quite a bit of anxiety. She's having a thoracic DPR multiple levels. A well-known patient too. I was wondering, do we give her a milligram of Versed before the timeout?
Sure.
I'm asking now the nurses know the rules. But
I don't know. Whatever you think.
very high.
She's already been here twice,
Yeah, this is certainly. She's
so we know her.
extremely nervous.
Sure. Well, I don't know. Why is she so nervous?
Just gonna give a milligram.
Sure. Just because you give us a anxiolytic doesn't mean it's a sedative. I mean, just use anxiolytic dose, and she should be, mental status should be there. She should be fully consentable. Or not consentable, but appropriate for the timeout.
Yeah, you'll be good, sir.
Fuck. Are both of those with the wrong pedal?
They have, yeah, both of them have the same pedal.
I don't want that pedal. I have a size 13 foot. You understand? Putting it into a little pedal hole is not a good thing. Before we buy anything more from them, I want that fixed. They need to find us the right pedals. Or they can buy it from Luminous, Boston. How much are the foot pedals? New. New? Yeah, then they need to buy us two new foot pedals. Okay? That's Luis. That's their option. But I'm not going to settle for the enclosed foot pedal. You tell them Dr. Duke has a size 13 foot, which is true. I do. And it's not going to fit into that cage. I don't need more constraints on my ability to care for patients. I need less constraints. And that, honestly, don't make that mistake again. That was your oversight. Okay? I mean, I'm letting you handle it because you're supposed to get us the same product we have now. Just a, older one. You understand?
Yes.
You can't let them cut corners on you. You got to be smarter than that. Because in the end, I pay the price, and I don't want to pay that price. I mean, if you told me ahead of time, I would have said no. Don't let them sneak things by you. You're smarter than them. He knows we have this kind of foot pedal. He should have said something. He services our machines. Honestly. How many of these foot pedals we have?
Well, right now we have
of the ones that I like.
Yeah, I have so two that you like. I have this one and extra.
No, yeah.
I'm back.
Yeah, just so you understand, the ones that are not the ones I like, they don't exist in my world. When I ask how many we don't have them. We have two.
Yeah, so two.
Okay, so those have to be traded out. I want you to call John today and let him know. Those pedals won't work. We need this one. Really upsetting. I feel like they tricked us. All right, you want me to call John or are you going to handle it?
Oh, I can handle this, sir. Hey, the suction is working?
What?
Suction is working?
You should handle it. It was really your responsibility. I'm surprised they pulled a fast one on you. I know you're busy and all, but you got to pay attention to the details.
It's the other side. Yeah. Thank you.
Just goes to show you can't trust people, Luis. You have to verify. Right? You can't trust these people in your business. You can't trust anybody. The only person you can trust is me and maybe Patel, and that's it. Everyone else, you got to have your eyes open, constantly questioning and asking for verification. You know what I mean? Until they earn your trust. I had to earn your trust. They should have to earn it too. I'm really disappointed they did that. It's really bothering me a lot. We paid a premium for those machines.
I call him after this case.
Huh?
I call him after this
Yeah,
case.
call them. What about Ohio? What's going on with Ohio?
Ohio is coming,
Do they have another machine?
yeah.
All right, did you make sure they gave the right foot pedal?
Yes, sir. Yes, sir.
All
I
right.
saw the machine.
We're going to need to buy more of these foot pedals from the manufacturer. I want 5 of them. 5 new. Can you buy them? It's 5,000 bucks?
Yes.
5 new. Order them this week and just store them. I mean, if we lose the foot pedal, the machine is useless. Right? If the foot pedal dies and we don't have a replacement, the machine is useless. So buy 5 new ones. Maybe even 10. 10? 10. Buy 10. Buy 10.
I find it more.
Ask him for a discount, but buy them. I want them.
I can find it. I find it on the other sides almost.
But are they used or are they new?
They are probably used, but
I don't mind a few used ones, but I want new ones too.
okay.
If you find a bunch of used ones, great. I'll take 5 new ones and then 5 used ones. But I need 10 spares. And that's on top of the ones that John's going to get us for the machines we bought. Tell him to take back the other ones. We don't want them. If he wants to just give them to us, we can take them, but we need the other pedal. How else can you operate this machine if it isn't with the pedal? There's no handhold device, right? It's only a pedal. Man, if those pedals die and we don't have a replacement, all those machines are going to be useless. Yeah. That's why we have to get, I want at least 5 to 10 new ones. Just, when are you going to buy that storage unit?
I'm still looking for it. I mean, I can go to Home Depot.
Go this weekend and buy it. Something big on wheels, lockable.
We have one over here, and actually the rest of that we don't use.
Well, you're going to put the pilot lights in it. You're going to put the rods in it. You're going to put the primary and secondary mirrors in it. You're going to put the blast shields in it. You're going to have a lot of stuff to put in there. So I want a big unit. You understand? And you're going to have to chain it down with a padlock so it doesn't disappear. You understand? That's an important thing to get done, okay? If you don't do it, I'm gonna go do it. Just tell me and I'll take care of it if you don't have time. I can take care of it. Maybe even a cabinet, you know?
Yeah.
Like a cabinet, a metal cabinet, because those pedals are big,
Correct.
right?
Correct. Yeah.
And they won't fit in one of the rolly things. I don't know,
Well,
at
they
least
have actually the bottom drawer is
that
actually
you could
big.
fit the pedals in there?
Yeah.
All right, maybe you need 2 of them, I don't know. But label it lasers, supplies. All right, just about done. Everything's going perfect for this patient. The anesthesia is amazing. He's sleeping, not giving us any difficulty with his airway, and the laser procedure is going very well. You can see how much scar tissue is in this crack right here. A lot of all that white stuff, the gold stuff right there is calcium. It's called dystrophic calcification, and the dystrophic calcification is your body's response to damaged tissues where there's inflammation. So dystrophic calcification happens basically in zones of chronic inflammation in your body. Any questions from our audience?
No current questions.
I think this guy's going to do fantastic. We're going to be done with his surgery in about 20 minutes, and he's going to be going back to his hotel with his wife an hour later. He'll be back tomorrow, hopefully to share his story, huh? Just about done. This is the back of the disc. This is the final part right here. Hey, hey.
Sorry, I'm just checking the elbows.
How much do I owe you for that? That wasn't the ulnar nerve.
Not the perineal nerve.
That was my perineal nerve.
I'm just doing a survey.
Yes, of course. That's what they always call it. That's how you stay out of trouble, right? All right, done here. I think we can go even more dilute than that.
I think that changing the degree of the swim position every like 20 minutes, 30 minutes, that will help with ulnar nerve neuropathy. If you just change position too, of how they're in the position. Like so, for example, I'm just moving it a little bit.
I don't know. I mean, I've done surgeries where they lay for 5 hours in that position, and they don't get an ulnar neuropathy. As long as the arm thing is low, it's not up here. Like, it's not like this, it's like down here. And the arm is more than 45 degrees, or 90 degrees, I mean. The elbow is more than 90, and it's padded. As long as you do those things, then you don't get an ulnar neuropathy.
I just like to double check.
Come on in, Jordan. Yeah. No, I think it's great. I've done so many like T-lifts for like 3, 4, 5 hours with the patient in the surrender position prone, just like this, with padded, with the arm board dropped and the arms at 90 degrees or less, or greater, I mean, sorry, less of an acute angle, more obtuse, and no problems. Now, if they do have a problem, it's always because they have pre-existing ulnar neuropathy, you know?
They have shoulder pumps, so they can't get the
Yeah.
positioning on the padding, you know?
All right. Any question from our audience?
No current questions.
Num num.
We just got a question.
Shot? All right.
This comes from J Bone on YouTube.
Oh, J-Bone.
They ask, "Hey Doc, good morning.
Good
how,
morning.
How intricate is doing a nerve test, and who are candidates for this test? Do some people have nerve issues near and around the neck that don't arise from discs?"
Yeah, great question. So, nerve test that I believe you're talking about is called an EMG, nerve conduction study. And it stands for electromyogram nerve conduction study. And basically, this is a test where the doctor is putting electrodes in your muscles, but also on your skin, and testing the function of the nerve roots and the nerves that come out of the neural foramen past the disc. And the reasons to do the test are several-fold. One, you want to know exactly which which nerves are affected. We're getting the dilator going in further. There we go. That should be good. You want to know which nerves are affected. So, believe it or not, you can have more than one nerve that's getting damaged. You could have 2, you could have 3, you could have 4. So it's good to know that ahead of time. And the nerve test is the most sensitive test, I think, that you can do to figure that out. So it's not surprising they would want it for that reason. Then there's other things that cause nerve damage in your arm. And they include neuropathy, and they include peripheral neuropathy and sensory motor neuropathy. And those are conditions that do not get better with surgery. I mean, the peripheral sensory motor neuropathy will not get better with surgery. Okay? But the entrapment neuropathies, like carpal tunnel syndrome and ulnar neuropathy, can, or anterior or posterior interosseous syndrome. So that's why the nerve test is useful, because it tells the doctor, number one, which nerves are affected and how bad they're affected. And number two, is there neuropathy, sensory motor neuropathy? And number three, is there an entrapment neuropathy? Grabber. So I think we use them all the time on our patients. All the time. They're very helpful. They're helpful because you can use that information to plan surgery, but you can also use that information to evaluate prognostically and diagnostically what else needs to be done. For example, if a patient has sensory motor neuropathy, then they need to see a neurologist, because neurologists treat that. And that's something that's caused by metabolic disorders, okay? What is a metabolic disorder? Something like diabetes, thyroid problems, electrolyte abnormalities. They can all cause neuropathies. And that has to be corrected by the neurologist. So I think nerve tests are extremely important when people have abnormal nerve or muscle function. We use them all the time. All right, take that. We've got basically 2 discs left. This is the number 2-3 on the right side, clearly damaged, pretty bad. This is a newer injury. There's some older areas right here, but you can also see there's a lot of new herniation. There's a big piece of herniation right there we're going to have to take out. The problem with a lot of these herniations, they're stuck down to the annulus, and that's why they become an annular debridement. See that? I can't even get it. It doesn't want to come. There we go. So you have to use the laser sometime to free it up, because it's stuck to the annulus from all the scar tissue. We were the first to talk about that and discover that here at Duke Spine. And that's why we started doing the annular debridements in the very beginning. Was basically to get the herniations out. Doesn't want to come. All right, great questions. Let's keep going. Any other questions from the audience? Huh?
To be continued.
What's wrong?
Thank you.
So we got to switch over the tank?
We have right now a standby.
Huh?
They switched already. It's fine. We're gonna finish now.
But is there someone else that can do that?
Jordan know how to do it, but
Huh? I can't hear you.
Jordan can do it, but honestly, we can let it.
All right, but the nurses should know how. They're part of our team, huh?
A little bit hard for.
Oh yeah.
I know that it's strong, but
All right.
I know you.
No worries. Any other questions, Henry?
Yes, we these next two questions come from Ali once more on on YouTube.
Hello, Allie. Welcome.
They asked, at the pre-op day check, do you also test for facet issues, or is that saved for the post-op day check?
Yeah, Allie, we check on the pre-op day if you have facet issues, and some people don't. They develop them after surgery. So we'll check after surgery as well. And when I mean after surgery, usually not the next day, but usually a few weeks later, you can have some facet issues. We do see that from time to time. It's actually, there's all these herniations. It's actually in our paper we published. You'll see that I think it's around 15 or 20% of patients with herniated disc pain, they also develop facet joint pain. So it is unfortunately a common finding. 20% is pretty common.
This next question from Ali, once more on YouTube. They asked, does the laser damage the annulus layers?
No, the laser does not damage the annulus. This annulus is already damaged. That's kind of like asking if shooting a dead person hurts them. Yeah, we're actually going through the damaged annulus right here. This is all dead, damaged. Huh? I don't see bubbly. Where do you see bubbly? This is probably the most damaged disc, L2-3. when you look at his MRI, it doesn't look that bad. Most doctors would not treat it. As a matter of fact, when I was doing his telemedicine conference, I was looking at this thinking, maybe we need to treat it, maybe we don't. And now that we decided we're going to treat it, because to me it just looked like it was damaged, but it was subtle. But now that we're in here, it's the most damaged of all the discs. So that's another reason MRIs are just not that reliable. You can't trust them. They don't tell you where the problems really are. You have to basically look at the physical exam and put everything together to make sense of it. Yep. Any more questions there, Henry?
No current questions.
I think I've taken more pieces of herniation out of this disc than I have all the other discs combined. There's actually a description for this phenomenon that's been around for a long time. It's called internal disc disruption, or IDD. It was described by some other scientist a long time ago, and I think they described it based on looking at dead people's discs during autopsy and finding that the discs were severely damaged in some people. And they called it internal disc disruption because the outside of the disc didn't look that bad. But the inside was totally fragmented into lots of little pieces. Like this. Almost done. We've cleaned out all those fragments of herniation. You see how the laser does the most of the work, but the surgery is just not possible without bringing in the grabbers too. You need both. And you never know with each disc which ones are going to need more grabber, which ones are going to need more laser. So you need both. Yep. This is looking laterally, like we talked about before. You can see the tear laterally going out the foramen. Got to clean that too. Wow, look at all that herniation that's gone now. We got rid of so much. Looks good. I mean, doesn't look normal, but it looks good. Right? It looks good for the work we're trying to do here. There's the nerve root right up there. A little bit more. Working right underneath the nerve root. Looking good. I have some of my patients that come here, they say, Dr. Duke, I've watched so many of your surgeries that I could actually do the surgery myself if I wasn't getting my back operated on. I love that.
So we turn off light too, guys? Thank you.
I like the patients that take the time to learn as much as they can. Okay, we're going to move on to the last disc, and we'll be done. And you could see just right up here all these little pieces of herniation. All right, wait a sec. Let me have a coker.
Can I have the cover, please?
Let me have another coker. Yeah. Come on in. Yeah, so we had a little trouble there with that last one because the laser had hit it inside the disc and basically welded the two pieces of metal together in the needle. And that was a bit of a challenge to get the stylet out, which is in the center. All right, let's get a shot. Come on, south, man. South, south. Shot. Why are you looking so weird there on that fluoro? Something's wrong. Shot. Jordan, you're killing me. The spine doesn't even look normal on the fluoro. You're doing something wrong. Can you at least show me where the needle is, please? You're shooting above it. Hiya. Okay. Look at that. All right, shot. What a bend, huh? Interesting. Shot. Alrighty. So, yeah, look at that. We melted the tip with the laser, but we're good. It's all out. Next, we're placing the dilator. This will be our 6th disc we're fixing on this patient. Shot. All right, Jordan, I don't know what you did with the settings, but you've done some weird stuff. We need to try to get it fixed. Shot. It's looking like a horse's spine. Shot. I can only laugh. Shot. I don't know. You've changed your setting or something. You know what? It's weird. I mean, is it the same there as it is up there, or is it the TV?
Oh, that TV. Let's put it the other side.
Yeah. Okay. So it's a TV. Did somebody change the setting on the TV?
No, it's if you click the button over there.
Shot.
It says endoscope and then back to fluoroscope.
Hallelujah, hallelujah, hallelujah. We figured it out. It wasn't the x-ray machine, it was the TV. Or it was a setting. Huh? I know, Jordan's like, I don't get it, it looks fine. What's wrong with this? Did you see it up there? You weren't looking. Then you realized it. So you made the diagnosis. Luis, you're a trusting man. Trusting me and my accuracy. All right, that should be good. All right, last one. Patient's doing fantastic. What time did you say we cut? 9:30?
9:22.
So we're coming up on 2 hours. All right. So six disc areas, 2 hours. Not bad. It's pretty much what I would expect. Any questions?
No current questions.
Great. We're going to wrap this up in about 15 minutes. That last disc had so many herniations, more than any other disc that I've seen on him. Try to have the laser ready.
Now it's ready. Yeah, now it's ready.
I'm hitting the pedal, it's not going.
Now, okay.
Yeah, try to have that done before I get on the pedal. Okay? Destiny? Otherwise, we're going to tell you you're pulling an Oscar. All right. Oscar had all kinds of excuses. It's okay, you're doing a great job. I'm just giving you a hard time. If I don't give you a hard time, who will? I mean, Luis won't. He's too nice. I got to give hard time for everybody. It's my job. All right. Someday I'll have a real operations person, and then they can give you guys a hard time. And I'll just come in smiling. I mean, smiling because everything will be perfect. And they won't have to get on anybody for doing anything wrong. I just get on the operations person. Oh yeah, look at that. Can I say mamacita? That is a big mamacita down there. Look at it. You guys see it? Doesn't want to come. I'm going to have to take it out in pieces. That's the herniation, or a piece of it. There's another piece. Any questions?
No current questions.
Oh yeah, we're getting it little piece by piece. And I think this is just a big herniation that's kind of stuck down to the annular tear. Almost kind of like the last disc that we just did. The problem is if I leave it here, it might come out and then give him a problem. All right. The rest looks pretty good. Hold on. More pieces. Doc, I'd say 8 minutes. I mean, assuming I don't have any surprises. All right. Thank you. So far, the surgery has gone really well for this patient from Chicago, Illinois.
So I might say that my experience with these patients in the last about 2 years,
Yeah.
they seem to always do better, vital signs, emotionally, pre-op and post-op, if they've watched the video.
Yeah.
I noticed that time and time again.
They watch the videos.
Seem to be a little calmer in the exam room, pre-op,
Uh-huh.
to them, and in fact, they do better with pain. Because they kind of understand, what we're doing
Yeah.
to their body to get them better, what Dr. Jitz is doing to get them better.
Yeah.
I encourage them to watch the videos. I think it's a great thing.
Yeah, Dr. Berndes has made the point that the patients that come here for surgery that have actually watched our videos of the surgery, they do better. Better is a general term.
Vital signs.
And just what he means is they're less anxious. They respond better to the anesthetics. They're more stable during the surgery. they recover better. You know, they know what to expect. Alrighty then.
They understand the discogram really well.
Yep, they understand the discogram. That's the part they don't like. They're all afraid of it. And I tell them, listen, it's a necessary evil, but you won't remember it.
And it was a lot easier than my root canal.
Huh?
The discograms are a lot easier than my root canal.
The discogram's easier than a root canal. All right, good. I've never had a root canal. I don't think I want one. Any questions, Henry?
My tooth broke after.
No current questions.
Jesus. Sorry to hear that.
I wish there was a
I try to stay away from dentists.
I wish there was a video I could watch. What if I would maybe film it?
Just about done. This is the last of that herniation at 4-5. No questions? Have we stopped streaming?
No. Everything's still going. We have a crowd and everything. I think it's just
They're just mesmerized.
yeah, they're just mesmerized, and I think more engaged in what you're saying. You know.
Awesome.
Henry is also mesmerized. How you doing, Henry?
Do you hear Dr. Bernes? He's asking how you're doing. How you guys are doing over in the broadcast room. Everything good?
All is well. Yes, I believe
Status quo?
he says is all good. I believe Carrie just stepped out for a minute to go talk to Ron.
No more problems with the broadcast anymore, huh? Since we fixed that issue with the backing up of the server constantly.
A humongous relief off my shoulders. I'll tell you that. Humongous relief.
All right, we've got about a minute left and we'll be done. This is the end of the herniation right here. Luis, will you let me know at the end of the day what's going on with my pedals? No, just by the end of the day. You know. I like John. I'm just a little surprised. Make sure he knows we don't want any other pedals. I'd say just another minute or two. Got to make sure I don't have a herniation here. So the things to take home about the surgery, folks. Number one, the small incision. It's a Band-Aid incision. It heals up in 3 days. The disc itself takes a year to fully heal, as long as you don't re-injure it. There are restrictions, but most people go back to normal activities by the next day. You just have to avoid any kind of heavy lifting for the first year. Keep it under 40 pounds of lifting the first year, and you can get back into golfing, swimming, and biking and doing the things you like to do, but there are time periods where we allow it. So you just got to talk to our team and you'll get those time periods. The second thing is it's bloodless. There's no bleeding basically. The surgery, you don't lose blood. Next is outpatient. You don't go to the hospital. There's no hospital problems. Things you contract at the hospitals like infections, pneumonia. Next, there's no downtime. So there's no blood clots that form in your legs or anything like that, bad things that happen. You can get back into a normal life right away. Next, there's no pain meds. So you're not going to get addicted to painkillers from the surgery, and all the pain that they create, like open back surgery. Next, there's no damage or destruction to your spine. We're going through a hole that's already there, so we're not doing laminectomies and removing bones and ligaments out of your spine. Next, you have the best anesthesiologist on earth, Dr. Berndes, right here, taking care of you. Yeah, and the best team of nurses. Got the best nurses right here. And of course, you're in Orlando. That's where Mickey Mouse is. So you get to visit Mickey and Minnie while you're here.
Sitting down, please. Thank you.
What else am I missing, Henry? Anything? Huh? Oh, no general anesthesia. You're doing a local sedation, twilight, so you don't have to have a tube down your throat.
Many patients ask about the nausea that what we get after this type of anesthetic.
Yeah, no nausea.
A 99%, 95% chance of not getting any nausea at all.
No nausea.
I mean, there are some outliers that weren't very
Dilator. Yeah, no nausea, no vomiting, because we're not using general anesthetics, we're using, yeah. Okay, just all around better surgery, better results, safer, more effective, faster healing, faster return to normal. All of that surgery done through, in his case, 3 little cuts on his back. You guys see this?
Yes, we do.
The average cut, 7 millimeters. I did 8 millimeters. So, but you can see these are tiny little incisions. They heal quickly. Oh, by the way, let's take a look at some of the pieces of herniation. Can you see this, Henry?
Yes, we can.
This whole blue towel is just full of chunks of herniation that came out. So if you thought herniation is one piece, it's not. It's many. You ready? Thanks, everybody. Great job. Hope you enjoyed. Yes. The use on the scope was a 6. No, sorry, 8. 8 today, because we did so many levels. No.
No?
I don't want any chemicals on it.
This one's
I like the fog, the anti-fog. That one has the chemicals. Yeah. Good morning, I'm Dr. Duke Majan at the Duke Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Duke laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home, And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional because it is an emotional thing. When you've been burdened with this pain for so long and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm 1/4" incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Duke laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things. And he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor in Sacramento for 35 years. And 2 months ago, I started to really feel bad. And I would go to him. And after about a month of going to him, and going to my doctor for some pain management for these symptoms, I finally figured out that something else was wrong with me. And so I asked the chiropractor, what can we do? Because what you're doing is not helping me. My doctor put me on pain meds, and they took some of the sharp pain away, but nothing was helping. And so being kind of a mechanical engineer, I decided to look into how my back was put together. And I requested an MRI from my doctor and from my chiropractor. And so that took 3 weeks to schedule. That's a long story. And I finally got an MRI, and I looked at it myself and realized that I had a cyst of some sort and that I had some problems with my lower discs. And that's when my chiropractor told me about you. He said, get on the internet and do some research and then call these people. So I called your store. They gave me some information. I FedExed my package to you guys, and a week later you called me. And about a week or two later, I got here.
Wonderful.
So, yeah.
And here you are pain-free for the first time in many years.
Many years.
Congratulations.
Yeah. Thank you.
Is there anything you want to say to your fans out there?
There is. This is a miracle. In Sacramento, everybody that I know said, why are you going? Why are you going to Florida? Why don't you find somebody in Sacramento? And I said, well, because I was referred to Dr. Duke Majan, and I've done a bunch of research on him, and I just have a great feeling about him. Not only that, he personally called me on the telephone because I told his people that I had some questions. And that's what sealed the deal. And so it took a while to get here, but it was worth everything. And I would recommend anybody send your MRI to this guy, and if he can help you, he will. Okay? Thank you, Doc.
You're welcome, sir. It's my pleasure.
Yeah, absolutely.
All right, go enjoy the rest of your
All right,
life.
thank you.
Okay, I hope you enjoyed that surgery with me. It was a 6-level Duke laser disc repair. And what we mean by 6-level, it's actually 3 discs, but because we're attacking the discs on 2 sides, because the patient had leg symptoms on both sides. Now, if his leg symptoms were just one side, say left side, I would have just gone the left side. But because he has bilateral neurogenic claudication, which is symptoms down in the legs with numbness, tingling, weakness with walking and standing, I knew the nerves were getting affected on both sides. I had to treat both sides. When I looked at the MRI, I could see that all 3 discs were having interactions with the nerve roots on both sides. So I recommended that he have 6 spots fixed, 2, 3, 3, 4, 4, 5, 1, 2, 3, 4, 5, 6, and that's what he did. And we've just completed his surgery. Some of the things to note: number 1, we talk about this quite often, is the position of the spine relative to the body surface, right, to the back of the skin. So some spines are, this is the skin, the plane of the skin where I'm standing and looking down. If that's the skin, some spines are here and some spines are here. Can you guys see that down there?
Yep.
So the ones that are further away, kind of, we call it anterior, those are harder to get to because I've got to make my tube go at a steeper angle just past the facet and into the disc, okay? And that's harder to do than a spine that's up here. And you can see how the position of the spine will change the angle of the tube. Like last week, we did a really big guy, and he took our tube to the maximum. Remember, you weren't here for that one. But we literally put the tube down to the hilt. I've actually had the top of the tube is actually inside the incision. That was a long time ago. I had one of those, but it's not common. Point is there's varying difficulties. And we just have to be able to be flexible to accommodate people. All right, other than that, the other thing I noted about this surgery was that the patient did fantastic from an anesthesia standpoint, right? For those of you who have watched many of these procedures, sometimes patients can be a little fidgety. We had a fidgeter last week. Apparently he's had that for his whole life. I talked to him afterwards, and he's just a very fidgety person. This patient was laying stone cold still, like a slab of marble. All right, he didn't move. So, of course, we prefer the non-movers, right? It's always easier to hit a target when it's not moving. But that said, you could see how there's variations with surgery. Same type of surgery, but there's variation depending on lots of factors. Some of them are patient-related with regard to their anatomy. Where's the spine located? How big are they? Some of them are behaviorally located. So, or behavioral issues with movement or versus non-movement. But overall, this patient's surgery went about as good as it could possibly go. Now, we did get into the L2-3 disc, and when you look at the L2-3 on the MRI, most doctors would not have identified that disc as a source of pain. They would have left it alone. However, when we got in it, we found more herniations at L2-3 than any other disc. And we call that internal disc disruption. It's a not well-known entity. It's all but forgotten about. It was originally described by anatomists that were dissecting spines in the lab, looking at the disc and noting that there was damage, lots of damage to the disc, even though the outside looked okay. The MRI is pretty good at looking at the outside of the disc. It's not good at looking at the inside. So the MRIs miss this stuff. I didn't miss it because I've seen it, I know about it, I have a lot of experience dealing with it. And it's a good thing we treated it because it's going to make a difference in his outcome. All right, questions?
Yes. These next two just come from Premier Media Group on YouTube.
Hello, Premier Media Group. Welcome back.
The first question asking, when will you be getting new lasers in, and any benefits to new devices?
We just got some new lasers in yesterday, 2 of them. The laser we use is a very special laser. It's manufactured in Israel. It's designed and built in Israel. It's built very well. It is a high quality product. There is nothing that comes close to it. The distributor and now the owner of that company is Boston Scientific, and they are making changes to, you all know what programmed obsolescence is, I hope. It means that the manufacturer designs a product so that it breaks, so that they can make money fixing it. It's disgusting. I hate it. It's anti-American. It's anti-me. I believe in fixing things and building things that last. So it goes against my core values. However, there is no alternative. So, because I've been made aware that they are going to be no longer manufacturing the good laser, the well-built laser, we're buying as many as we can, knowing that in the future we're going to be busier and busier. The new laser they want costs twice as much, and it's programmed to break down, and and only be fixed by their technicians. So that's going to drive the cost up massively, making surgeries more expensive and more unattainable for my patients, which I don't want. So we have acted, and we're now buying refurbished lasers that are perfectly working in good condition, but that have a few years behind them. So I hope that answers your question.
This next question from Premier Media Group once more on YouTube, asking how long post-op till patients can use swimming pools or baths?
So swimming pools can be used by patients 3 days after their surgery. Bath, 3 days. That's the shortest amount of time. That assumes that you have normal wound healing abilities, aka you're not diabetic or have vasculopathy. You don't have problems that would interfere with your wound. If you are diabetic or have some problems healing your wounds, I would wait a week. So let's just say a week to be safe. You can go back in the pool, you can go in the hot tub, you can go in the bathtub. Now, you can shower the next day after surgery. I don't want you soaking for a few days. And the other thing about the pool, when you go in the pool, I don't want you doing, what is his name? Mark Spitz, butterfly. Who was the really good swimmer?
Michael Phelps.
Michael Phelps. I don't want you beating Michael Phelps in a race, okay? It just got to be gentle swimming.
And that is it.
All right, no more questions. I hope you enjoyed the surgery. It went fantastic for our patient. He'll be being discharged in about 45 minutes back to his hotel. Our next patient comes to us from Canada. He's Canadian. He's got 3 discs as well that are causing back pain, but we're not fixing them on both sides. One of them is on the left, the next one's on both sides, and the next one's on the right. So we're going to go left, bilateral, right. So it's really 4 spots. And then on top of that, he has facet joint pain. What's the difference? Well, there's 2 things that cause back pain most commonly, the discs and the facet joints. So when I examined him, I found that he had facet joint pain on the right at L3-4-4-5-5-1. So we're going to go in and do the Duke plasma rhizotomy to kill those pain nerves after we're done with the disc repair. We're going to break it up into 2 separate surgeries. We'll probably end the stream on one, and then we'll start the next one as a Duke plasma rhizotomy, lumbar, right, L3-4-4-5-5-1. So be prepared for 2 separate surgeries coming up. Thanks for joining us. Have a wonderful